Hi, welcome to our online meeting. Today, Professor Muralidharan will be addressing our group. Professor Muralidharan graduated from Madras Medical College in 1965. He then did his MS General Surgery at JIPMER in Pondicherry and MCH Cardiothoracic Surgery at CMC Vellore. He then served as Professor of Cardiothoracic Surgery at CMC for a few years before he went to Coimbatore to set up and run a cardiothoracic unit at Kuppusamy Naidu Memorial Hospital. He served as president of the Indian Association of Cardiothoracic Surgery in 1998. His many trainees are doing extremely well here in India and abroad. I would now welcome Murray to address our group.
Thank you, Badri, and thanks everybody for taking time off the late evening or early morning to be with us today. With the topic which is so wide, I thought I would just confine myself to certain problems which exist in the mind of many people. And therefore, if there are any controversies there, how we should be handling them. I will also spend a little bit of time on the various procedures which can be done and what investigations are required. So, truly speaking, it's not a one lecture on just a particular problem. It's a multiple bits and pieces of various procedures and various little topics which matter today in the face of growing knowledge about various conditions which exist. So I titled my presentation today as Random and Rambling. Of course, I am rambling a bit, but that's part of the thought process which I have now and having reached maximum senility. I propose to keep this rather light-hearted and not very serious, so forgive me for making probably inappropriate comments now and then. But that's the only thing which kept us going in cardiothoracic surgery and ability to laugh at yourself and laugh at others also. So this coronary artery surgery has come of age in India. It was in 1975 that the successful surgery for bypass surgery was performed by K.M. Cherian in Madras, and this was presented at one of the meetings held in Chennai, the erstwhile Madras. Did not meet, the people at that time didn't give it any importance, and the talk was in a small hall, not in the main hall, in Taj Coromandel. This led to a lot of ill feeling among the presenter who said, I'm doing something unique and I get consigned to the outer spaces. But all this happens in life, and then he took it in his stride and then went on with his work. Today, between 60,000 to 1 lakh of cases are performed all over the country. Official authenticated figures are not available because many of us, I'm talking about cardiac surgeons, do not provide the data and tried as best as the association could not get a database going with all details. People are fought shy of coming forth with numbers and what is the outcomes. We said in the association, numbers are fine, don't worry about the outcomes, at least let us know what is happening. So the figures which we have are usually from companies, the medical industry, who tells us about the number of oxygenators supplied and all that, so on and so forth. Yeah. Change. Now, we constitute an extraordinary 25% of the world's population. We are also about 60% of the world's heart patients. And you look at the WHO, the ischemic heart disease burden is pretty high. So that is where we are. So it is the number one cause of death from both low and middle income countries. So what makes us special? Angiograms done on South Asians being separated from the Caucasians, smaller luminal diameter of the arteries, higher grade of stenosis, and higher multivessel disease. These all add to the problems of the disease being more severe in the South Asians. So it is inevitable that isolated outcomes, CABG, poorer outcomes of South Asians because of these pre-existing factors which are there. Diabetes is part and parcel of our daily life now. The excess diabetes is a severe contributor of the morbidity and possibly mortality of these patients which we encounter. Now, what is this due to? There are a lot of visceral heart fat in the abdominal area, liver, and around the heart. This is part of the masala study. Anything to do with India is either curry or masala. So this masala study, I had to look up to see what it is. The masala stands for Mediators of Atherosclerotic South Asians Living in America. So this, they found a lot of visceral fat in the abdominal area, liver, and around the heart, which were contributory factors for coronary artery disease and its severity. Now, we have looked at the WHO problems, and then they do say that the ideal weight for the Indians should be much less than what is uh, talked about for the rest of the country, rest of the world. So this is a factor which we have to factor in when we talk about how we are going to manage this problem. Now, a lot of talk recently has been there is aspirin a drug which is to be used or not to be used, and what are the problems? So aspirin blocks a cyclooxygenase that reduces inflammation. It does definitely lower the risk of death. Low dose aspirin daily for 10 years can lower risk of cardiovascular disease by 10%. I've been taking aspirin for the last 20 years, so that's why I'm here with you today. What are the risks involved? Stomach ulcers and abdominal bleeding are problems which can occur. In an emergency situation, when you're having think you're having a heart attack, you're supposedly advised to pop a 325 milligram aspirin within 30 minutes of a symptom. You can add clopidogrel if you have, but I think by and large, if you have symptoms and you have access to the drug, nitroglycerin at that time is useful. This is useful only if people are known to have coronary artery disease and have these medications available. Those who don't have it off the shelf, it becomes a problem. Remember that a diabetic has no classical symptoms like the other people, other patients. Diabetic knocks off the neural transmission, therefore their symptoms are very much reduced or not at all. So as I explain to patients, it's like if you're at a traffic signal, you expect to see an orange before you get a red. But in diabetics, you miss the orange, straight away you get a red, which is when you have a emergent heart attack. That's with regard to aspirin. Statin is being touted and talked about as a very, very important uh, medication in the armamentarium of surgeons. What does it do? It lowers low density lipoproteins, which are essential. The pleiotropic effects include reduction of inflammation, thrombus formation, and improving endothelial function. Statins work by inhibiting HMG-CoA reductase. Now, atorvastatin is one of the drugs which are in use. I am not responsible for putting up this particular slide. My colleague did it. I don't know if the medical industry has sponsored him for some program. The intensive therapy of statin is certainly advisable. You target a level of LDL, low density lipoproteins, below 70 milligrams. Anything higher is likely to cause more problems. What are the risks involved? If you find you're likely to get rhabdomyolysis and elevated liver enzymes, it can interfere with glucose metabolism. Rhabdomyolysis is something which is very severe in patients who get large doses of statins. Some of them have unbearable muscle cramps and pains, and that forces them to reduce or stop the drug. So this is something which we have to remember that this can happen. Okay. Now, when you go to bypass surgery, what are the indications, really speaking? The classical indications which were existent earlier have been watered down. It even now, mostly it's a left main disease where the main artery of the supplying the left coronary system gets disease, or multiple areas of disease, triple vessel disease, and low cardiac function seem to be the primary factors which are responsible or become indications. Today, there are a lot of procedures, stenting, for example, which in many patients, stenting is being advocated as a first line treatment, and CABG comes only for those who need extensive work or who have comorbid conditions like maybe severe diabetes. So, when you do this procedure, you have to use some artificial material away from the heart, which is harvested from different parts of the body. You either take the mammary artery or the internal thoracic artery, as they call it in America, from the underneath the breastbone. There are two on either side, left and the right. They are used. Today we are also using extensively the radial artery, provided the ulnar artery supply is normal to the hand. Both radial arteries and both hands can be used. Then you have the age-old saphenous vein, great saphenous vein, which is harvested from the leg. So this is something which has been in vogue from 1970s onwards. It is a good conduit. It is easy to harvest. It doesn't create too much problems, but the longevity of this is certainly less than the mammary artery. Therefore, by and large, arterial conduits are preferred. Gastroepiploic artery has also been used when other vessels are not been used and are not available for use again. So this is something which we have to keep in mind. There are a variety of conduits which are available, and one has to temper which one you use for what.
Heart bypass surgery creates a new route, called a bypass, for blood and oxygen to reach the heart. Heart bypass surgery begins with an incision in the chest, and the breastbone is cut, exposing the heart. Next, a portion of the saphenous vein, which is very large, is harvested from the inside of the leg. Pieces of this large vein are used to bypass the blocked coronary arteries, which are arteries that supply blood to the heart. The venous graft is sewn to the aorta, the main artery of the body, and to the affected coronary artery to bypass the blocked site. The internal mammary artery from the chest may also be used to bypass a clogged artery. Several arteries may be bypassed depending on the condition of the heart. After the graft is created, the breastbone and chest are closed.
This is what was being done routinely. Nowadays, there are variations. There are procedures which do not have to cut the entire breastbone. There are modifications which you can do. But when you talk about what are available, there are a lot of thought about doing total arterial bypass surgery, which means you use the left internal mammary artery, the right mammary artery, and the radial artery, providing arterial grafts to all arteries which are affected. The contention is that the arterial grafts are better long term. So, that being the situation, one expects to achieve a better outcome. As you can see in this pictorial presentation, the left internal mammary goes to the left side of the heart, the right internal mammary, the radial artery goes to the right side of the heart, and another accessory artery goes to the circumflex system. This way, You use the maximum number of arteries as far as possible. Having said that, majority of situations today can do primarily the internal mammary artery and saphenous vein grafts are being used most often. So what did we think about? We in India we did a multicentric Indian study where we called it the Promote Patency Trial. We had 220 patients. 158 of them were done op-cap, which means you didn't use a heart-lung machine, you used the stabilizing systems to do the procedure, and you had 162 patients on pump, which are equally matched. At the end of 1 year, there was no difference in the two groups as regards outcome. One patient in each group needed repeat vascularization. But however, one must remember that this was in centers which have sufficient expertise to do the procedure so that the procedure is uniformly performed and the outcomes can be expected to be good. This was performed and our institution was one of the partners in this trial. Then you have the RAPCO trial, which is in Australia. They compared long-term patency of radial artery versus right mammary artery versus saphenous vein graft. The radial artery was used on the second most important coronary artery, which is the circumflex system. There are a few important points to remember when you use the radial artery. It's a muscular artery. It should not go into spasm. It should be less handling. The graft must be placed on an artery which is almost more than 70% stenosis. A graft which has got a native flow, if it's placed on a graft that has got a relatively good native flow, then it is likely that this graft will not function for long term. The results, they showed a 10-year patency was significantly higher than free radial artery, right mammary artery, or saphenous vein graft. So this compared the numbers and proved beyond doubt that the radial artery was a significantly better conduit than the right mammary artery as an isolated free graft or a saphenous vein graft. Now you talked about left main. Left main is the most important artery in the heart. It supplies the two main branches, the left anterior descending and the circumflex. Any occlusion of this artery can result in immediate fatality and is often been referred to as a widow's artery. Now you have this left main. If you have today, people are advocating stenting for these arteries. So if this stent is going to be used in the distal part of the left main, as it divides into both the left anterior and the circumflex, the long-term outcomes are poor. However, stenting and CABG have comparable long-term outcomes for ostial or shaft left main disease. This is not being done routinely everywhere. However, it is being thought of vigorously by aggressive cardiologists. Still, the conservative cardiologist or practical cardiologist might shift these patients for surgery rather than offering them stent alone. PCA is certainly associated with higher rates of target vessel revascularization, which means you may have to redo a procedure or take other steps to achieve complete revascularization, which should be the goal. I think last month we had a talk by Dr. Chandrasekhar Verma about diabetes. He talked about various drugs which are used. And I think when you have these newer drugs, which is the new kid on the block, empagliflozin and dapagliflozin, are sodium glucose transporter inhibitors. The benefits of these drugs are many. They tend to improve cardiac function. They can be improved and do better with those in cardiac failure. They improve the renal protective effects. And overall, this is a wonder drug, and really speaking, it's a new kid on the block. So there are a lot of patients who are on these drugs. This drug is a good drug. It does a lot of good to the patient with cardiac problems. However, patients on these drugs undergoing surgery are prone to develop euglycemic ketoacidosis in the perioperative session. Now, this is something which one has to be aware of. So, the awareness came to us rather suddenly when we encountered a patient who had this problem and we didn't realize what we were dealing with, eventually ketoacidosis, and we had to spend a lot of time and effort to get him out of the system. Thereafter, we became a little more cautious. Now, so thereafter, we decided that we have to suspend, stop the use of these SGLT2 inhibitors at least 3 days prior to surgery. There are multiple reports of this drug being stopped for 3 days. Some have talked about it for 5 days, and therefore it becomes necessary to be aware of this, especially when these patients are going for surgery. It is believed the surgery promotes the response to this drug in a negative fashion. So when you have patients on this, you have to check for ketones after surgery, initiate a glucose insulin infusion afterwards. And please note the ketoacidosis value of more than zero point 0.6 millimoles per liter is indicator of the severity of the problem. Now, as we mentioned, we had a video showing a long incision and the breastbone being opened completely and the procedure carried out. Today, there are a few centers carrying out minimally invasive bypass surgery. Whether they're able to provide complete revascularization or not is a problem which has to be looked at later. Technical difficulties are there. A long period of training is required. The cost of this procedure is certainly more, and time involved is also much longer. So, in select cases, it may be offered. By the same yardstick, smaller incisions can be used for endoscopic vein harvest. Instead of long incision, you can make small incisions, which is more cosmetic. We can also use this for harvesting the radial artery. This part of this endoscopic vein harvest is being extensively used in our unit, and we have studies done after the procedure, including angiograms, to show the veins harvested this way are disease-free at the end of a year plus and functioning well. So, of course, it involves a dedicated team to harvest this and probably use this very effectively. Just the other day, we're talking about artificial intelligence, we're talking about robotic surgery, and technological advances have facilitated all these procedures. Hybrid surgery is for surgery in a vessel, and in an inaccessible one, a stent may be done at a separate sitting, for which you need a hybrid lab, for which you definitely have to have both facilities for angiograms and surgery at the same sitting. So the cost for a hybrid lab ranges into a couple of crores, and you have to invest on the console, the hybrid machine which is required. There are various models. The earlier model was the Da Vinci machine. Now there are newer models coming up which are probably not that expensive but are still serving the purpose of providing help for robotic surgery. Having said this, we have to look at some numbers where you have to press the panic button. When you have a cholesterol which is more than 130, triglycerides more than 150, LDL which is more than 100, and the HDL has to be below 40 milligrams. Earlier, it used to be mentioned that you have to have a 12-hour fast before you take the sample for lipid testing, but I don't think this is any longer insisted upon. You can take the sample any time of the day. In that way, that means you have the sample done and you know your figures, then you can work on how you can control the problem. The BMI is a very important minimally invasive test. All it requires is a gadget which shows you the body circle, body weight, the body mass index can be calculated, and the figures which are presently mentioned are 18.5 to 24.9 as normal, and anything over 25 is overweight. Going by the figures, most of us are abnormal. Women 23 and 24.9 and 20, more than 25 is obese and not underweight. Now, what are the investigations and when can you do the investigations? When you have a strong family history, when you have comorbid conditions, if you are by perchance a smoker and you have a high cholesterol or a familial history of lipid disorders, you should think in terms of evaluating yourself periodically. Generally speaking, we say above 45, you have to do a testing periodically, and it all depends on the environment you're in, the kind of pressures you have, and the kind of diet you're involved in. The simplest investigation, of course, is a 2D echocardiography, and this has got so many modifications, Doppler, tissue Doppler, and so on, will tell you the heart function. This is a simple thing which is done by placing a probe on the chest and studying it. Now, if there is any controversy, if there is any doubt that one area is well, you go to the next step, which is stress. A routine is not the answer. A routine ECG does not show any symptoms of ischemic heart disease that the patient is an ongoing problem. So you have to do a stress test. What is a stress test? Basically, it's a stress treadmill test, which is done patients walking on a treadmill and the graduated increase in the speed and the incline so that you achieve target heart rate depending upon your weight, your age, to see what is happening. A stress test is a provocative test and it shows you if there's any ischemia which is brought out in the presence of stress in the form of exercise. If somebody is unable to do a stress test because you already got a knee problem or joints problem and is unable to walk on a treadmill, you can always do a dopamine stress echo, which means you give the drug which will increase the heart rate, increase the cardiac function, and then the same recordings can be taken. There is also a myocardial perfusion scan, which is a nuclear scan, which is done by injecting a drug into the radioactive isotope into the vein, and then the myocardial function is assessed. It's assessed both at rest and after maybe 24 hours, sometimes 48 hours. But the purpose of this delayed assessment is to see if there were any areas which were not perfused adequately at the first time when it is being done, the patient also exercises at the same time. And if there's any area which is not perfused adequately, when that area shows a deficiency in perfusion, this can be checked. When you repeat the test after 24 hours, you find that area which was not being perfused is now being perfused, which indicates that area was ischemic. Of course, CT coronary angiography is something which is now being talked about. There are people who are advocating CT coronary angiography as a routine test for eliminating people who have coronary artery disease instead of submitting them to an invasive procedure like a coronary angiogram. However, it must be remembered that CT coronary angiography is not the gold standard. That alone is not enough for one to carry out bypass surgery. All it tells you is that you need to be investigated further. This is a useful test when you're talking about assessment of patients who have been operated earlier and who are now coming in for checkup for various reasons. However, the gold standard is coronary angiogram. This used to be done by the femoral root until about last 15 years, and now it is done in the radial artery. So the patient walks into the cath lab in the morning, has the arm prepared, and the radial artery is cannulated, and the angiogram is done. All the views are done, and the patient is able to go home in the next 4 hours. So this is certainly an advance and has made it more convenient for people to do it. The skill sets involved have been worked out and they are able to do it very easily and this can be done. So this is being done extensively in all parts of the country today. Now, when do you need a cardiac MRI? When you have perfusion defects, when you have doubts about the functionality of various segments of the heart, then it is necessary to probably do a cardiac MRI to see if these areas can be benefited by intervention or not. So this is something which is probably at the end of the scale. It's not so much for coronary artery disease as it can be for find a useful place in congenital heart disease and in valvular heart disease in assessment. I thought we should look at some of the points which now we have looked at. It is by and large the most researched medical procedure. When you talk about the surgical procedures which are there, the improved outcomes are enormous. Standard mortality risk is less than 2%, irrespective of the state of the heart. Even those with a poor ventricular function can be salvaged by this procedure. Whether you can restore them to 90% of what they are, you will not be able to restore them to 90. At least you will get them to about 80% of their previous functionality so that there is improvement. There is no doubt that this improves symptoms. No doubt it improves the quality of life. So which these are the two most important things. It improves your lifespan, it improves your quality. And nobody thinks it's a end all of everything. It's all said and done. It becomes a palliative procedure because the disease has to be contained. And that disease can be contained only by the use of medications, diet, and exercise therapy. And all this contributes to make the occurrence of redo coronary artery surgery or recurrence of the disease, it is reduced to a very large extent. I think I have rambled and randomly touched on various topics which are pertinent today. However, I'm sure there are areas which I have not touched upon, and I'm open to uh, take on any questions you may have. And thank you for listening to me. I hope you have got some insights as to thought process of a surgeon when it comes to this. I do believe in this operation. I have seen patients who have benefited with this operation, and if necessity arises, I will also have it performed on me. Thanks.
Thank you, Murali, for this clear presentation. You covered a lot of things.